Good morning, everybody. Just giving it a couple of seconds for folks to trickle in, and then we will get started. Great. A couple of logistics reminders. Next slide, please. Thank you, Nancy. The webinar, we're still meeting virtually, so this webinar is available on your computer or by phone. Live captioning and ASL interpretation is being provided, and you should see our ASL interpreter, Julie, on your screen. To enable closed captioning, you'll want to select the live transcript or CC icon on your Zoom toolbar. And as always, the meeting slides, transcript, and recording will be archived to the California Department of Aging's California for All Ages Equity and Aging Resource Center. We are saving time for public comment, so attendees who are joining by phone can press *9 on your dial pad to join the queue, and I will announce the last 4 digits of your phone number to hear from you. If you are joining us by Zoom, you can use the raise hand icon on your toolbar to join the queue. And for additional public comment, if you think of things after we adjourn, you are always welcome to email engage@aging.ca.gov. We're going to pivot a little bit on our roll call this morning, just so we have enough time for discussion and for public comment. I know it's a pretty packed agenda, so we'll kind of scroll through the slides slowly, and rather than going through and identifying all the members, I would invite our committee members to use the chat to introduce yourselves, maybe just list your name and organization, say hello. We'd love to hear from you. Great, thank you so much. And with that, I would love to introduce Director Susan DeMorris from the California Department of Aging.
Thank you, Maria, and good morning, everybody. So happy to see you all and to be here with you today. We've been thinking a lot about the 2-year anniversary of when California closed down, and this is a committee that, I think of it as this is the original stakeholder group that spun off from the Master Plan for Aging Stakeholder Advisory Committee. It was formed in the early days of the MPA work, and it's just really exciting to be here with you all this time later as a standing group, as a standing advisory committee. And I want to thank the wisdom of those who first planted the seed. Rigo is on here, who first suggested that there be a standalone equity advisory group, and I'm so proud that it has grown. Kevin, others who have joined, that we've now added additional members and that we're meeting regularly. And I want to thank Maria, Sarah, and Amanda for planning today's agenda. It was hard to know there's a lot to cover in these 2-hour meetings just quarterly, and it's hard to pick and choose what topics, because there are a lot of other topics we could be talking about today. But I'm glad that we're talking about what we are talking about today. And I wanted to just plant one seed. Catherine Blakemore is one member of the, she chairs the Alzheimer's Advisory Committee, and last week when they met, and Derek Lamb, who's not with us today, but a member of this group, talked about social isolation and the impact on nursing homes and residential care facilities as California is opening up. This group can really continue to keep a spotlight, especially on nursing homes. And we can move to the next slide, I think. Oh, well, we'll get to that. I think I just wanted to put a flag on the nursing home rate reform issue and the proposal in the governor's January 10th budget and the conversations that are ongoing. We've had some experiences in the last couple months through the long-term care ombudsman program, where 2 sizable facilities were closed because of, at the suggestion of the federal government. There we go. Thank you. For non-compliance, a large facility in Bakersfield, another one up in the Sonoma County area, both of them serving significant Medi-Cal populations. And what we saw through the pandemic in terms of the outcomes in nursing homes, the incidence of COVID, hospitalization, mortality in nursing homes. I think that this is an issue that I would invite this work group to focus on, if not today, between meetings, to really put an equity lens on nursing facility financing and where California goes from here post-pandemic, especially for nursing homes. So you've probably seen in the governor's budget that this is one of the years where we will be re-examining the rate structure for California's 1,200 nursing facilities, and we'd welcome your thinking on that. It's a bit of an extension of what Catherine and Derek raised at the Alzheimer's Advisory Committee, but there's not, of all the stakeholder groups, 7 or 8 of them that are in existence through the Master Plan for Aging, there's not one that's focused on nursing homes. And I would just ask that you keep this setting in mind at the equity work group. That's my request today. And let's see, what is the next slide? And in the spirit of that, we, as part of year 2 of the Master Plan for Aging, as our work continues, we are resuming our Wednesday webinar series, and we held our first one last week on CalAIM. It was wildly successful, great panelists, great planning. We had a few hundred people join us, and these are going to be more policy focused this year, and they're going to lift up the recommendations from the master plan and also start seeding future recommendations for the next 2 years of the master plan initiatives. So you're all invited to join us on April 6th, when we'll be focusing on the Biden administration's recent recommendations around nursing homes, as well as the state's opportunity to reform the rates. So you're all invited for that. And that's the end of mine. So now, with a full agenda, I want to turn it over to Maria, or shall I introduce the next 2 presenters?
That'd be great. Yeah.
Okay. So now we're really happy to share with you one of the key programs at the Department of Aging, HICAP, Health Insurance Counseling and Advocacy Program, and our efforts to modernize the HICAP program. So we're delighted to hear from Brianna, who just did a really extensive research project on behalf of the HICAP program, and my colleague Sutub, who will be joining us too, who leads our program at CDA. So Brianna and Sutub, take it away.
Wonderful. Sutub, would you like me to start?
Yes, I can do sort of a little recap of where this, what you're presenting on is over summer of 2021, with support of the SCAN Foundation, CDA engaged with Brianna with ATI Advisory now to look at how to opportunities for modernizing the HICAP program in California, and looking at how HICAP is performing in the state, and as well as the learnings from other states. So I'll tee that off for Brianna to jump in. So thank you.
Yeah, thanks, Sutub, and thanks everyone for inviting me and having me here today. It's nice to see many familiar faces. We conducted this research over the course of the summer. I think it was May through August last year. And for those of you, maybe before we get into the research, just to level set and make sure everyone is familiar with HICAP. HICAP is California's term for its SHIP program, its State Health Insurance Assistance Program, which the main charge of SHIP programs nationally is to counsel Medicare beneficiaries on Medicare coverage as well as long-term care coverage. So keep that in mind as we make our way through the presentation and talk about Medicaid coverage and some other complementary services that we'll be touching on. So the research that we did was funded by the SCAN Foundation and was aimed to provide the Department of Aging with a menu of options, essentially, as it thinks through how to modernize the SHIP program, the HICAP, really with the aim, as defined in the Master Plan on Aging, to serve more beneficiaries and to do so while improving cultural competency and language access. So really with an equity lens throughout all of it. And I will say that the charge was really wide. It was anywhere from, should the department think about shifting HICAP out from the Department of Aging to the Department of Insurance, all the way to how should counselors be trained? How should they be deployed across our communities? So we covered a lot in this report, and there's a link at the end. We're going to just cover a few pieces of it today. And to inform the research, we did 2 surveys. One was a broad public survey of California beneficiaries, stakeholders, received 374 responses to that. We had a separate survey that went to the AAAs, the area agencies on aging, the 26 of those that administer the HICAP program in California. Some of those HICAP or some of those AAAs administer the HICAP program themselves and deliver services directly to beneficiaries. Other AAAs subcontract with community organizations in communities, and those programs deliver the HICAPs or deliver the HICAP services. So that's why you see more than 26 responses there. So we had some HICAP community organizations and some AAAs respond. So a lot of great information on operational considerations to improve and modernize the HICAP. We also conducted a number of interviews with California stakeholders, national subject matter experts, and then current and former SHIP directors in other states to try to identify best practices and opportunities to consider in California, looked at literature reviews, and did a SWOT analysis to identify opportunities for California. So we can go to the next slide, thank you. So overall, key takeaway in terms of how the HICAP program is doing in California. The results of our stakeholder survey found that, generally speaking, the majority of individuals that access HICAP are quite satisfied with the services that they receive. So 65% ranked the services that they received 4 out of 5 or 5 out of 5%. That being said, California ranks on the low end of the scale nationally in terms of how many individuals it serves as a proportion of overall Medicare beneficiaries. So on average, California has been reaching about 1 to 2%, a few percent of its overall Medicare beneficiaries with its HICAP program. Other programs nationally may serve 5 to 10%. So increasing that is certainly a goal to keep in mind. I also highlighted here for this group, specifically the strategies that the HICAPs mentioned they deploy to support dual eligible individuals. So individuals eligible for Medicare and Medicaid. And we'll get into this more because I think it's an important equity consideration here, understanding that these individuals have multiple chronic conditions, multiple IADL needs, many of them do. Some are community well. It's a really diverse group, but a really critical group when you're thinking about the complexity of navigating Medicare and Medicaid coverage. So what the key takeaway here from the survey findings is that HICAPs deploy different approaches to serving these beneficiaries. They have different structural components that they have built out to train beneficiaries, and they all take different approaches. So looking across the state, if you're in a different region, you might get a different type of service if you're a dual eligible beneficiary. And we'll get into that more in a minute. So I think we can go to the next slide, please. This goes a little bit more into detail on some of these approaches. The key point here again is that not all of these supports and not all of these organizational design elements are uniform across the state. So different HICAPs take different approaches here to collaborating with other organizations for referrals, to delivering different materials, to counseling on what it means to be in a CalMedi Connect program versus a DSNP versus a PACE, and that is a lot of acronyms, I know. So we get into the importance of creating a robust infrastructure for counseling dual eligibles in a little bit. But wanted to take a moment to level set here that counseling, referring, educating, screening happens. It just happens differently. There are pockets in particular around the 7 counties that have CalMedi Connect, which is the financial alignment demonstration. Those 7 counties have very robust HICAP programs designed to serve dual eligible individuals. So there's pockets of best practices that the state can learn from. And then I think we can go to the next slide, please. So here are a few more key findings that I wanted to call out for this group, specifically related to approaches that HICAPs take to provide accessibility for people with limited English proficiency, as well as individuals with disabilities. And again, approaches varied across programs. What we did learn was that from the survey of beneficiaries, you'll remember it was 53% ranked their experience with HICAP overall very favorably. When we asked about experience with accommodations for disability or for LEP, we learned that that number went down significantly. So about 32% of folks were satisfied with the accommodations that they received. So there's an opportunity there to really make the approaches more robust and approaches more uniform, I think, to providing accessibility for individuals. Overall, in terms of these approaches listed out here, for individuals with limited English proficiency, leveraging bilingual counselors was the most common response that we heard across the HICAPs. But we also heard that competitive wages and ability to deliver competitive wages to recruit and maintain these counselors was a big challenge to being able to deliver those services. So a few other approaches, technology has been used, various different materials have been developed to try to accommodate individuals. And then same with, so for the accessibility for people with disabilities, I think the first bullet here really are kind of standard accessibility basics that should be across the board and often are in most cases in varying forms. And then a couple of the other modes that different programs take in terms of engagement with GLAD, engagement with different CBOs and partners to try to reform and modernize their program, or excuse me, their approaches to serve different populations. All right, so here we have the 10 recommendations, and there's a lot of detail again in the full report on each of these recommendations that I'm not going to walk through in detail today. Many of these are operational in nature, so thinking through, I think 3 of these are thinking through the rebranding potentially of HICAP to make the name more understandable, looking at a statewide marketing campaign, redesigning the website to make it more accessible. There's also a few here about internal operations from CDA and the data sharing system. So SHARP data system here, number 6, is the resource that CDA, HICAPs, and AAAs use for case management of the HICAP services, as well as reporting. Revamping that to allow it to capture key metrics, particularly around equity, is really important in order for the department to be able to measure its impact and how it's doing along its goals. I want to talk more specifically about a strategic roadmap for supporting dual eligible individuals, as well as touch on the relationships, referrals, and feedback loop recommendations as well. But before we do that, I do want to spend a minute on this overall developing a strategic roadmap for HICAP, which is the #1 recommendation here. Oh, sorry, you can stay on that slide for 1 more minute. Thank you. So the first recommendation here is to develop basically an umbrella strategic roadmap for HICAP. And this could be using various recommendations that you see here. And really the goal here would be for CDA to define what are its equity goals, what is its modernization goals for HICAP program, and then work back as to what it needs to put together to achieve those goals. So some of that could be some of these recommendations. It could be other considerations that it learns as it's going on undertaking its stakeholder engagement and other efforts. So I will say that, and then we can go to the next slide and talk a little bit more about duals. So the recommendation here was to develop a strategic roadmap specifically for dual eligibles, understanding that this population is unique and the Medicare, Medicaid program complexity, if you are a dual eligible, and navigating that complexity is a real challenge. Again, high caps are intended to serve and counsel on Medicare eligibility Medicare coverage and long-term care coverage. And what we heard when we were talking both internally to folks in California as well as to national stakeholders and other SHIP programs is that this is not unique to California. There's not a clear understanding of where SHIP should start and stop in terms of setting their expectations for counselors of how far they should go on counseling dual eligible beneficiaries. When you ask a SHIP counselor, do they counsel dual eligible beneficiaries or do you counsel on Medicaid? It might mean to them Medicaid eligibility. But what we might want them to mean, or what we might think it should mean, is counseling on the variety of different integrated care models out there for beneficiaries, right? So for a community well dual, they might benefit the most from an over-the-counter benefit, over OTC benefit. And that might be what's most valuable for them to go to the pharmacy and have a quarterly stipend. For an individual with multiple functional needs or behavioral health needs, having a care manager through an integrated dual eligible special needs plan and MLTSS program, that might be most valuable for them. So creating an infrastructure that enables SHIPs to counsel individuals in an individualized way to allow them to access the coverage that's best for them is kind of the gold standard of what a counseling program would do for dual eligibles. But defining where SHIP starts and stops on that is really the key here. And I think that's the first piece and probably the most critical to this strategic plan is where does the California Department of Aging want to set that standard, recognizing that SHIP's charge is to counsel on Medicare and long-term care. And there are very practical concerns around training counselors who are already limited in terms of accessing those counselors with the skills and capabilities, and they're volunteers mainly. So how do you define that? How do you develop a program that can deliver on a more robust counseling program? And maybe that's having a subset of counselors who have more robust training and kind of a specialty workshop to send folks to. Defining that's first, and then how we get there would be kind of the rest of this strategic roadmap, which I'll touch lightly on a few of these. The next step along the line would be naming an integrated care model. This consideration is more for the Department of Healthcare Services. What we've learned is that for dual eligible programs, having a name such as CalMedi Connect makes counseling beneficiaries easier, as opposed to having a broad DSNP MLTSS aligned program is more challenging to communicate with beneficiaries. Engaging other departments, which we'll talk about more, is critical to the process. Developing those tools, what those tools look like to help counselors as well as to help the SHIP program managers achieve the goals that the department lays out. Ongoing engagement with advocates, with beneficiaries, with the SHIP counselors themselves, and then making sure that the programs are up to date, mainly through coordination with Department of Healthcare Services and CMS, and updates on integrated care program developments on an ongoing basis, especially as CalMedi rolls out, will be critical. So that was a lot. I think that's everything on this one. We can go to the next slide, please. And then the last one I wanted to call out is really just an emphasis on collaboration and understanding. A lot of this is already being done today. The California Department of Aging's SHIP team is fantastic and has a lot of strong relationships that they meet with folks regularly. A lot of this is happening, but I just want to emphasize that this is an important piece of the puzzle, and doing, if as a part of the modernization program, doing this systematic review of where the Department of Aging is already doing these things, and where are there opportunities either at the department's level or across the SHIP programs, the HiCap programs themselves, to make more connections with other related entities. For instance, in Iowa, we know that they've developed a really strong coordination program with their Ryan White HIV/AIDS program. So is that an opportunity, and can we be educating SHIPs, HiCaps across the state of California about creating such opportunities? So again, a lot of this is happening, but wanted to emphasize that there are different strategies here to really maximize HiCap through coordination with other entities and departments. So with that, this is the link to the report. I'm happy to go back and talk about any of the recommendations we covered or others that I didn't get into any detail on. Let's see. And there's my contact information, and I don't know if Sutub or others, if you'd like me to, I see there are a few questions that came in through the chat. If you want me to start reading those.
Yes, thank you, Brianna, for the presentation and for all the work that you've done in this effort. And yes, our next section here is, I think we have time to respond to questions, and I'll save some time for myself to share sort of what CDA is up to post these recommendations and the pieces of work in play. But maybe we can tackle some of these questions first and have time for more. So it looked like, let's see here. I saw Marty's hand up first, and we'll just
Sure. Okay, thank you. Really appreciate the presentation and the emphasis on the duals for HiCap. Thank you for that. And I think most of the people on the group know that I'm a big fan of integrated care, so I like that emphasis as well. What I wanted to call out was one additional issue. I worked in a health center for many, many years where we were interested in qualifying people for Medi-Cal who were already on Medicare. And, you know, the portion, there was a much smaller portion of low-income older people that were actually on Medi-Cal than were eligible for Medi-Cal. And I assume that's still the case, although I haven't seen the latest data. One of the biggest most profound impact of getting HiCap to work with Medi-Cal is the income effect on people that are potentially duals. So obviously your Medicare Part B premium, Part D premium, co-pays and deductibles, those all put dollars in your pocket immediately if you haven't been on Medi-Cal, but you're eligible to be a dual. So I think it's worth emphasizing that almost before we get to the integrated models. So you can help people, the HiCap program, by being sophisticated in terms of getting people on Medi-Cal and counseling them through that process, can do an amazing amount of good in the equity realm, low income, Black and brown communities in California. So that's my comment. Just want to call that side of the dual program out.
Yeah, Marty, that's fantastic, and thank you for that. And Sutub, sorry, I saw you getting off, but I'll just quick reaction to that. I think that's totally right. And when I think about what these different buckets of counseling could be, depending upon the cohort of dual eligible beneficiary, you have kind of the individuals that might benefit the most from supplemental benefits. You have individuals who might benefit the most from kind of zero premium, zero copay, and ensuring that they have those subsidies and are maximizing them depending upon the coverage option that they choose and they elect. And then you have the care management, care coordination bucket, right? So all of those should be considered when counseling anyone who is a dual.
Great, thank you.
thank you, Brianna, and thank you, Marty. Going to Catherine.
Thanks. I put a little bit of this in the chat, and then Brianna covered it at the end of her presentation, which I also thought was really excellent. Very exciting work to kind of make systems work better. So 2 comments. One, the Health Consumer Alliance really does a lot of this work already around getting people eligible. And it seems that I think systems have to work really, it's sort of almost beyond coordination, but sort of who's best situated to provide advice about which of these things to most effectively use the resources that are available, right? And so I would encourage really taking a deeper dive into what the Consumer Health Alliance does, which is a statewide program funded by the state to provide advice on kind of any kind of healthcare without regard to income, and figuring out what they could offer that might supplement high cap programs rather than reinventing everything at the high cap level. And then the second piece, just to let you know, I'm on the California Access to Justice Commission, and we have a project with the state bar to help identify legal problems that people may not know that they have, and are going to be doing some work to sort of figure out what the right messaging is to get people to be able to access advocacy lawyers that can help them solve that legal problem. And one of the strong recommendations is that focus on access to people can help with healthcare, and trying to figure out the messaging of that. And so it seems like your work around messaging and rebranding connects to this project that we're doing. So I would love to connect you with the people that are doing the work at the access to justice level around we're really going to be testing messages, like what words need to be used to help people understand they have a health related problem. I mean, a health insurance related problem that somebody could help them with. Testing those messages, actually seeing how many times people actually are able to link to current forms of assistance and so forth. So I'll just plant a seed with that, and maybe we can talk separately about that.
Oh, thank you, Catherine. As Brianna noted, as one of the recommendations and what we are looking at here at CDA is how do we rebrand? But before we rebrand, it's sort of that market research. What are the perceptions of consumers on navigating to get their resources, navigating Medicare and Medicaid, and what is sort of the naming, the marketing that would be required to do that? So we are thinking through that, but would love to touch with you on sort of what you're doing and might inform our work as well.
Yeah, perfect. Thank you.
Thank you. Are there other questions? Kevin.
Thank you for this great information, and exciting to see some real opportunities here. I wonder if you could speak a little bit more to, particularly looking at HICAP from the equity perspective, both what we learned, you touched on some of the strategies that HICAPs employ, but what are we learning about how well HICAPs are serving communities of color, LEP communities, LGBTQ communities, people with disabilities? Like, do we have data on some of that? And as we consider reforms, are there recommendations specifically to things that could be done differently from data collection to actual program design and service delivery, so that we really are building this system with equity at the center of what we do differently moving forward?
I can start, and then if you'd like to add anything in as well. Great question. So this was, again, the 5,000-foot view. So we were only able to go so deep in our research here, but we looked at this issue, and really it goes back to that very operational piece of the SHARP data system, which is what CDA leverages for the counselors to input all of their information whenever they counsel a beneficiary. It gets reported back to the CBO, the HICAP, then to CDA, then to the feds. And that database, that system needs to be updated in order for information to be captured, excuse me, that would allow them to really include measures that would allow to for an evaluation of any real value around equity issues. So that was a key piece of that recommendation, that infrastructure needs to be in place in order for the measurement to occur, because today it's very high level in terms of kind of light, the touches that we're given. I think there are some high level demographic information being captured, but being able to report that back and synthesize that reporting structure system isn't in place yet. When you looked nationally, it was something that I asked folks And other states and other programs were really interested in how they could better capture issues of equity in terms of their SHIP programs and how they were performing, but also create infrastructure within their contracts between state agencies and SHIP subcontractors, so the AAAs, et cetera. And there are a couple of states that have started to develop and try out some innovative contract measures to incentivize more equitable approaches. So there's one state, I believe it was Washington, was starting to provide performance-based funding based on percentage of individuals who had limited English proficiency. I did not identify any sort of approach that was related to outcomes from an equity standpoint. So it's definitely an area that nationally everyone was interested in that I spoke with, but no one had solved it in terms of how to measure and then how to address it. So I think what California is doing now is you'll be among the leaders in the country.
And I guess sort of data, since we know that data is hard and not wanting to wait on data to identify issues that we might know about already. I wonder if there was any kind of red flags or green flags that popped up as you were doing the research of communities that were clearly not being reached, or examples of counties or programs where they had done a really good job building relationships and serving a community that could be modeled on. Like, did anything kind of come up as those red light or green light of like, oh, here's an equity issue that we can see, even if the data isn't there to support it, that we're hearing about from the community?
It's a great question. I think, again, it was very high level, a lot of these. So I think that makes me want to do another scan specifically for that. I think we heard some pockets of more the innovation around, yes, we're doing these outreaches to this particular community, but I think that the silence that we heard in the surveys is probably what we'd want to dig into more in terms of what's not being done, and that wasn't covered in what we accomplished so far.
Yeah, and I'll just add to some of the things we are looking at and doing in terms of resources, looking at making what's available for our high cap subgrantees, those resources more accessible with language, including language translations, Spanish, additional languages. We are asking our high cap sites on what have we learned during the pandemic as well, on online training tools and resources. Now that you have high cap counselors who are not able to attend sort of trainings in person, what are those challenges? How can we address that systematically, or provide tools and resources to address some of those needs as well? So, and then as Brianna said, I think there is a need for more data. The SHARP system is very I would say dated in terms of the data collection, and how do we collect data on a uniform basis? So again, we can make some actionable, data-driven policy decisions in terms of how to build and support the high cap program.
And maybe I'll answer. I see Jax Kelly asked a question around, do high caps provide consumer-friendly infographics about dual eligibles or other services, and noting that infographics can overcome language competency issues? And that's a great point, great question. I think it's happening, yes. There are, again, I hate to use this, but there are pockets, there are programs that have really robust approaches to communicating with beneficiaries. So I forget exactly which one it is in the report. There's one high cap that has a robust YouTube channel that it's created to communicate with beneficiaries and try to make information around Medicare more digestible. And I do know that others are creating different types of materials. I think that infographic idea is a great one that maybe can be incorporated more widely.
Great, thank you. And I just want to interject to see if any other committee members have questions, and if not, we will thank Sutub and Brianna, and we'll transition to our next presentation topic. Quick pause for any more questions. Rigo, go ahead.
Thank you. Thank you for this very informative report and update and all the great work that you're doing. I guess I have a question with regards to what are your thoughts, and maybe this will come, Sutub, you might talk about this, but in terms of how you plan to directly engage communities that you're trying to reach in the development of outreach messaging. I know that you've done surveys, but it'd be great to think about focus groups and really go in deep into certain communities that you want to work with, and essentially co-creating, right? And in that process and involving members of the community. So that's one question. And the other one is you shared the challenge of attracting and retaining counselors. And so part of the formula obviously is getting the right message to effectively reach communities that are often underserved and hard to get to. But then the flip side of that is having the right balancing capacity to serve those individuals once they come in. So certainly I think be interested to hear more about what are some of your thoughts, ideas around staff attracting bilingual staff, as well as being able to retain. And I know that you did mention obviously funding to support salaries and so forth, but so anything beyond that would be great to hear.
Yeah, so I think I can start, and Sutub definitely jump in as well here. The compensation is definitely the big one that we heard. There are also other programs across the country, and I think some programs within California that go above and beyond in terms of volunteer recognition and counselor recognition and SHIP program manager engagement and recognition. And what I mean by this, so Florida, for instance, you access their SHIP, I think it's Shine in Florida, their SHIP page, and the first thing you see is a volunteer recognition of the month, volunteer of the month. And they spotlight that individual and the incredible work that they do, recognizing so much of this work is done by volunteers, not just, so you have the compensation piece, but you also have the volunteer piece, and recognizing and engaging and keeping those individuals satisfied and feeling like they are valued is another way to accomplish that kind of retention factor. And other programs do have a variety of efforts, so kind of public facing recognition. There's also different approaches to having one-on-ones on a regular basis, so counselors and SHIP program managers at different levels, so counselors within each HiCap program, and then maybe from the CDA level you'd have additional engagement of SHIP program managers to help them feel engaged and heard, and just overall satisfaction to keep them there above and beyond or outside of the compensation piece. And that is, some of that's captured under one of the recommendations we didn't get to feature today around creating a HiCap Technical Assistance Center. So a really robust infrastructure to support SHIP program managers as well as counselors. And a piece of that is keeping them engaged and satisfied.
Yeah, and I'll just add to that. I think what Brianna touched upon is there's pockets of innovation across our HiCap site and the state, but I'm not sure if we've taken that opportunity to really capture those insights and best practices on targeting populations of need and sharing that with the HiCap network. You have pockets of HiCaps doing really great things, but we, I think, at the state have an opportunity to bring some of those learnings together and support in strengthening the network, without having to recreate, the wheel or having to do our own research on what might be done elsewhere in other states, but what's being done in California to do that, to serve our population. So.
Okay, well, thank you so much, Rigo, for that great question. And I want to thank Sutub and Brianna for an amazing presentation and a robust discussion. And we're going to transition into our next topic. Thank you, Nancy. And while we're doing that, I'm just going to drop the link to that ATI report into the chat for everyone one more time who's interested in doing a deep dive and looking at those recommendations. And let's turn to Julia.
Good morning, everyone. Can you hear me?
Yes, we can hear you.
Great, thank you. My name is Julia Figueroa McDonough. With the generous support of the Blue Shield California Foundation, I'm working with the California Labor and Workforce Development Agency on direct care workforce issues. I'm joining you today from Kanab, Utah, which is an extremely beautiful place, but my internet connection is spotty. So I'm gonna have to stay off camera to make sure I can preserve the audio connection. And I'm joining you, as I said, from Kanab. I want to recognize that I'm standing on the ancestral, traditional, and contemporary lands of the San Juan Southern Paiute tribe, the Pueblo Zuni, the Hopi tribe, and Ute tribe. I'm offering this land acknowledgement and affirm Indigenous sovereignty, history, and experiences. Before Sarah delves into some of CDA's specific initiatives, I'd like to provide some background on the direct care sector for context. First, a high-level overview of where direct care workforce work is performed and who pays for it. We know that by 2030, we'll be facing a shortage of anywhere from 600,000 to 3.2 million paid direct care workers in California. There is, of course, a large unpaid workforce of family caregivers that is facing its own shortage and barriers, but today's presentation focuses on the paid direct care workforce. These workers provide care in a variety of settings. One category is home care. Income eligible individuals, generally meaning people who qualify for Medi-Cal, can receive care at home through the In-Home Supportive Services Program known as IHSS, a program run by the California Department of Social Services and each county's public authority. This might be very basic for many of you, but we find it helpful when talking about the workforce to give an overview, sort of map out the sector as a whole. So bear with me for this part. The blue shading on this slide indicates public pay, while the green indicates private. Direct care workers can also provide care through private home care agencies. There are a limited number of Medi-Cal home and community-based waivers that are available to income-eligible individuals to pay for home care, but the majority of home care agencies rely on private pay clients. Then there's the gray market, where individuals or their family members hire caregivers directly outside of an agency, often paying off the books or under the table. There are a wide range of publicly funded services provided in both home and community-based settings, mostly through Medi-Cal waivers, aimed at allowing individuals to stay in their homes and communities as long as possible. Some examples are the programs of all-inclusive care for the elderly, known as PACE, and the Adult Day Health Care Centers, or ADHCs. And there is, of course, care provided in congregate or group residential settings. There are assisted living facilities, including both residential care facilities for the elderly and adult residential facilities for individuals who may need 24-hour assistance, but not necessarily medical care. RCFEs are for individuals over 60 and range in size from small 6-bed boarding cares to larger assisted living facilities that can house over 100 people. These facilities are primarily private pay, but there are also a limited number of Medi-Cal assisted living waivers available to income-eligible individuals. ARFs, or the adult residential facilities, are for those under 60 and can be subsidized through various government programs, including disability and the regional center programs. And then there are medical facilities, with skilled nursing facilities providing the highest level of care and intermediate care facilities providing, as the name suggests, an intermediate level of care. SNFs and ICFs are primarily publicly funded. So to the next slide, please. Moving on to the type of work performed and how that work is categorized. Personal care assistants, or PCAs, are the largest group. They provide assistance with activities of daily living called ADLs, like eating, dressing, bathing, and toileting, and also often with intermediate activities of daily living called IADLs, like housekeeping, meal prep, and medication management. PCAs work in all settings, home, congregate, and community. Required training varies by program. IHSS workers fall into this category, for example, and are required to attend an orientation. Certified nursing assistants, or CNAs, assist with ADLs and IADLs, and also with general patient care and some clinical tasks, like blood pressure readings and range of motion exercises. They work under the supervision of licensed medical or nursing staff, primarily in hospitals and skilled nursing facilities, and must complete 60 hours of classroom training plus 100 hours of supervised clinical training. Home health aides, often referred to as HHAs, perform essentially the same work as CNAs, but in a home or community-based setting, also under the supervision of a licensed nurse or therapist. They are required to complete 120 hours of training. Direct support professionals do similar work as PCAs, in addition to helping develop behavioral management plans and managing medical records for individuals with intellectual or developmental disabilities. They work in both congregate and community settings and must complete 70 hours of training. Now let's move on to talk about who does this work. Next slide, please. Direct care workers are overwhelmingly women of color. In California, 80% are women and 47% are immigrants. Close to 40% of the workforce is Latinx, while API and Black workers make up 25 and 12% of the workforce, respectively. API workers are represented at just under 2 times their statewide population, and Black workers at just over. I want to highlight that here, as is so often the case with aggregate federal data, we do not have accurate information on Native American or First Nations workers for the usual reasons, small sample sizes and large margins of error among them. These metrics were culled from the Bureau of Labor Statistics and the 2015 to 2019 5-year public use microdata sample and the American Community Survey, all federal data. I'm not an expert on data by any means, but I do know that before we can effectively solve a problem by allocating appropriate resources, we need an accurate picture of that problem. We'd love at the Labor Agency to learn more from this group, what kind of best practices would be recommended at the state level to address this issue. Direct care workers earn so little that over half of them qualify for public benefits. Next slide, please. For a sense of perspective, comparing mean wages for the first quarter of 2021 in California, we see that direct care workers earn significantly less than gardeners, housekeepers, and short order cooks. Next slide, please. Here we see that wages for direct care work have not kept pace with the astronomical growth in demand for that care. In the last decade in California, the number of personal care aid and home health aid jobs has risen by 473%. Although CNA growth has been slower, most likely due to accessibility of training and certification, the overall growth rate for all direct care jobs was 130%. Wages, by contrast, have barely risen at all. CNA saw the greatest increase of a little less than $2.25 an hour since 2010, while wages for PCAs and HHAs rose $1.40, and for all direct care workers, only 35 cents. Next slide, please. Looking toward the future in California, what would be the impact on both our economy and our health of improving wages and working conditions? Estimates of a living wage in California vary depending on a variety of factors, including region and household size, but never fall below approximately $18 an hour. So payment of a living wage starting now would result by 2030 in an additional 3.6 million in economic output, 165 million in public assistance savings, 1.3 billion saved in turnover costs, 9.1% increase in staffing, a 17 to 21% increase in retention, and fewer ER visits and hospitalizations. So overall, significantly improved patient safety and health, and over 50,000 badly needed direct care jobs. So the question of how to increase wages for direct care workers is a complicated one. As we'll hear more about from Sarah in a minute, the current year's budget includes significant investments in the direct care workforce, but with the exception of discrete salary tiers for certain direct support professionals, does not provide for permanent wage increases. This is in part due to the nature of the funds, the majority of which come from the American Rescue Plan and expire in 2024. A temporary infusion of cash cannot sustain a permanent wage hike. That is why stakeholder advocacy around at a national level, the passage of at least portions of the Build Back Better Act, and at a state level, implementation of the Corporate Transparency and Elder Care Act and reauthorization of AB 1629, also known as AB 81, is so crucial. With that in mind, next slide, please. We turn toward our exciting current investments in a thriving direct care workforce. We have for the current fiscal year a total of $946.4 million invested in direct care workforce, over $400 million invested in personal care assistants, $120 million in CNAs and home health aides, and $100 million for PATH. And we have just over $100 million for direct support professionals. These investments are primarily 83% in-home and community-based care, with 7% allocated for residential care and 10% for programs spanning both settings. Now I'll turn it over to Sarah Steenhausen, Deputy Director of Aging Policy Research and Equity for the Department of Aging.
Great. Thank you so much, Julia, for that excellent framing of today's discussion. It's so wonderful to be here and to see all of you. And I appreciate the opportunity to give you a little bit of an overview of California's Direct Care Workforce Initiative, kind of what the framework is, and then a little bit of a focus on what CDA is leading. We are really excited to hear your input, your questions, your feedback, as we're just starting to launch our stakeholder engagement on this initiative. So this slide really, I think, is important because it recognizes a lot of what Julia was touching on, is that this workforce crisis is really complex, and solving it includes addressing a number of different fronts, including ensuring cultural competency of the workforce, ensuring a living wage, ensuring access to career ladders and career lattices, having access to high quality training, ensuring language access for the training and for the workforce in general, and then providing incentives for the workers. So recognizing all of that, I just think it's important to point out that we are going to focus in on some of our current initiatives, but we also know that we're super excited and proud of these investments. And we know that this is just the first step. And by no means do we see this as a one and done. This is going to be a process that we will rely on partnership and advocacy for the years to come. Next slide. So what I wanted to do is kind of build off of what Julia just provided, an overview of the 2021-22 investments of approximately $946 million. But I also wanted to highlight some of the really important initiatives that have been proposed in our proposed budget of 22-23 of $1.7 billion to really move, the current year investments are focusing a lot on developing training and stipends and incentives across both the home and community-based services direct care workforce, as well as opportunities for training and stipends for our nursing homes and congregate facilities. But this year, the governor is proposing $1.7 billion to expand and build the pipeline. So there's an initiative to develop a pool of 25,000 community health workers by 2025, to build the pipeline of social workers, as well as nurses, a multilingual health initiative, and a psychiatric initiative as well, to really build out the workforce with an emphasis on equity and language access and cultural competency throughout. Something that's really important, I think, for the issue and how it intersects with the master plan for aging is that with all of these initiatives, we really need to ensure that there is the aging lens applied throughout. So, I encourage all of you to be engaged on this and to providing input as to how you see these various opportunities where they intersect with the aging sector, because we know that, older adults, people with disabilities are really in need of the specialized services and supports across the continuum, and ensuring that our workforce has the capacity to meet their needs. What can we do within these initiatives to ensure those needs are met? So, as the process moves forward, we always appreciate hearing that input. Next slide. So now what I'm going to do with that kind of broader perspective on the state's larger workforce initiative, I'm going to talk a bit about what we're doing at CDA with the workforce initiative that was awarded to us through the Home and Community-Based Services Spending Plan. One thing before I talk about it, I do want to note the importance of partnership in developing these initiatives. While departments across the Health and Human Services agencies are leading different aspects of the broader workforce initiative. The success of this initiative relies on cross-department and cross-sector collaboration. So something that's really exciting is that while CDA is leading this initiative, we're working really closely with our colleagues at the Department of Healthcare Services, Department of Social Services, Healthcare Access Information, the Health and Human Services Agency, as well as the Labor and Workforce Development Agency, because ultimately, all of this will not be successful. Sorry for the sound of my cell phone. It's ringing somewhere, but I can't find it. It won't be successful without these partnerships in place. So next slide. So I wanted to focus on what is included in California's Home and Community-Based Services Spending Plan for this initiative. You'll recall that the spending plan was approved earlier, I think finally signed off on by the federal government, by CMS, in January of this year. And essentially the spending plan was authorized through funds from the American Rescue Plan Act, which provided a 10% increase in the state match for Medicaid dollars. So essentially it provided approximately an additional $4.5 billion to improve access to and the service delivery within our home and community-based services network. A key component of that broader HCBS spending plan initiative is the workforce issue and addressing the workforce crisis. So in particular, the Department of Aging is carrying out an initiative that's kind of going hand in hand with the IHSS Career Pathways Initiative, where we're trying to build off the work they're doing for the IHSS program by developing a direct care workforce training and stipend program for the home and community-based direct care workers who are not IHSS workers. So that's quite a mouthful, but it's basically the workforce that is not captured by IHSS. We know that IHSS is a critical component of our HCBS infrastructure, but we also know that there's many other direct care workers who provide services and supports to Medicaid recipients. So essentially, what you see here is what's authorized in the spending plan to provide services or training and stipends to improve the skills, compensation, and retention of direct care workforce sector. So it's a very broad range of workers that could potentially fall in this category, and I'll talk a bit about what that means. But again, the purpose is to focus on developing training and stipends to improve the skills and cultural competency of this population workforce. Next slide, please. So the way that we are framing this initiative at the Department of Aging is kind of through this 5-component process. First, we want to really focus on delivering and making high quality training available and accessible to all workers in this category. And that includes cultural competency and language access as well. The second component is ensuring access to these stipends and incentives for the workers. So not only will these trainings be available free of charge, but we're actually going to pay the workers to take the trainings and develop an incentive structure for staying on in those jobs for a number of months and getting an incentive for that. We really want to look at focusing on career ladders and lattices. So providing opportunities for advancement so that these jobs are valued and seen as really a key step in a career that is meaningful across the continuum of care. Fourth, we want to focus on evaluation. So this is evaluation not at the personal level and ensuring that the actual trainings are helping improve the skills and competency of the workforce, but also evaluating the broader initiative so that we can understand what works, what doesn't work, what are some of the promising practices and lessons learned. And then finally, I think something that's so exciting about this is we're really trying to think about how we invest in the system infrastructure to, with the goal of developing learning and Leadership and Learning and Innovations Institute. So this is kind of developing a broader platform, which is considered called a learning management system that looks at how we can invest in these services, these trainings ongoing. So while we only have until the end of, essentially the end of 2023 to spend the $150 million that has been dedicated for this purpose, we really want to ensure that that funding can be utilized as an investment into the infrastructure with some sort of institute that provides a framework for leadership, learning, and innovation. But throughout all of this, what's really important is to recognize the cross-cutting issues of language access, cultural competency, utilizing data to advance our efforts, and building on cross-sector partnerships. Next slide. So I want to talk a bit about the target population. I noted how the language in the home and community-based services spending plan was quite broad in terms of what potential direct care workers would be eligible to receive training under this initiative. We're of course trying to cast as wide a net as possible because we have the resources to do so and because we know there is a need. So we're working closely with our department partners, healthcare access and information, as well as departments of social services and healthcare services to ensure that we're really capturing the whole population that could be eligible for this, and that we're not duplicating at the same time what some of the other services and trainings are that are being administered by the other departments. So we're examining, how we can reach out to the direct care workers that are home health aides, social workers, the personal care assistants in the community that are, provide services, say through the community-based adult services program or through the MSSP program that are not IHSS programs, and other workers. It could be dietitians or transportation providers or activities planners, anybody that's providing direct care services to Medicaid recipients in the community that are not IHSS providers. So these workers, in terms of the programs that they're aligned with, we want to target the CBAS program, community-based adult services, as well as multi-purpose senior service program, Alzheimer's daycare centers, as well as the PACE program, which is Program for All-Inclusive Care for the Elderly, the assisted living waiver providers, the home and community-based alternatives waiver providers, AIDS waiver providers, as well as the smaller assisted living facilities, the 6-bed facilities that are licensed as RCFEs. They have, as we all know, a lot of the SSI, SSP, and Medi-Cal population. So we believe that we can capture a lot of the workforce by targeting these facilities and providing access to these trainings as well. We are going to be working closely over these next few months to define this target population, and we'll be engaging our stakeholders as well to make sure that we're being comprehensive and in our efforts. Next slide. So here's the framework for what kind of how we're operationalizing this initiative. And again, this is just the framework of where we are now. And we recognize that as we get more stakeholder input, it's likely to evolve. But one very important principle that I want to note is kind of building off this concept of partnership. We do not want to reinvent the wheel. And so that is why we're working so closely with our colleagues at the Department of Social Services to leverage a lot of the really good work they've done already in building their career pathways program. So that starts with this 5 training pathways. We are going to leverage the work that the Department of Social Services is doing and make their curriculum and portal available to all the workforce that I just outlined. So they have a 5 training pathways program that's going to be launched later this year that has 2 general pathways and then 3 specialized pathways, providing curriculum and advancement opportunities for the workforce. So what's super exciting about this is that they're building this system. We're going to be able to leverage it and plug into it and expand off of it where we can for our population. And that's where we get into this kind of specialized curriculum grant program, where we're going to administer some sort of grant program that targets the providers or the associations, nonprofit organizations that can help develop specialized curriculum for the home and community-based services direct care workforce. And it would provide the funding to develop the curriculum and to administer the trainings as needed, and to also pay the recipients for the training. We're developing the systems so that we have the processes in place to track how we're going to pay the direct care workers and how we're going to track the incentives as well. I do want to also note that in terms of the incentives and the stipends, we're going to be modeling the same structure off of how the IHSS program is carrying out their career incentives, their workforce training program, so that we don't have a different set of incentives that kind of creates an unequal playing field for the direct care workforce. So we will model it off of how they're doing it, theirs as well. Third, we're going to be investing in this kind of broader Learning and Innovations Institute. That the concept right now is that it could provide a kind of standardized platform, learning management system for not only the workforce and workers, but also providers and the network leaders, so that across the aging and disability service system, we would have a really, build an institute that allows for exchange of ideas, best practices, leadership development, as well as training for the workforce and other trainings as well, and technical assistance opportunities. So that's something that is kind of a broader systems goal, and we will not be able to leverage this funding for the entirety of the Institute, but we're certainly looking at how we can leverage it to make a good down payment into it. And then finally, and very importantly, we're looking also at how we can evaluate this entire program to have it so that we can ensure that we're learning from what works and where we can make some changes along the way. So hopefully it'll be a real-time evaluation so that we can have course corrections as we're building it out. Again, I just want to reinforce that this is the very early stages of the framework that just is getting developed over the past several weeks, but that our stakeholder engagement that we'll be launching soon is going to really be informing our how we operationalize this. So I'm also excited to say that internally we are out for in the process of hiring a assistant director of the Direct Care Workforce Initiative. So that individual will be responsible for kind of leading this initiative and working in partnership with our other state departments. So we're going to be building up a team to get this off and running, but really looking forward to hearing input and feedback on it. So our next steps are really to hear from all of you. We're going to be engaging a wide range of stakeholders, which includes the workers themselves. We want to hear from workers and understand what would be meaningful in this process. We also want to hear from providers, and we also want to hear from consumers and advocates as well. And all of the stakeholder engagement is going to help inform the framework's development. And then the goal is to launch it in partnership with the Department of Social Services later this year. So again, we have to have these funds expended by the end of 2023, but we're really hoping that we can make some longer term investments that kind of set the infrastructure for the state for today and moving forward. So that is the overview, and I'm happy to take any questions or comments that you may have.
We have a couple of hands raised. Oh, is
Sorry.
that Donna?
Betsy has questions.
Betsy, go
Hi,
ahead.
everyone. And Donna too, I guess.
Yeah.
Donna's muted though. Donna, do you go first?
Oh, okay. I wasn't sure. I thought Michael had his hand up first.
Oh, sorry, I didn't see.
Yeah. Anyway, first of all, I want to really thank you, Sarah, for this this whole concept and moving towards this institute. I think this is going to be a wonderful way to not fragment our system and get the same type of information out for everyone. So I'm looking forward to the stakeholder process and being able to help incorporate where we can the information that has to do with family caregiving and across this population. I particularly like that there are incentives for people and so that they can take these courses, because sometimes that can serve as a barrier to education.
Thank you, Donna. And I just want to note the really critical importance while we're talking about the paid direct care workforce in this initiative, we also recognize how critical it is to address the needs of our family caregivers in partnership with the Caregiver Resource Centers. So really look forward to engaging on that. I mean, one of the things we've talked about internally is with these trainings becoming available, they'll be free. So there's nothing that would stop family caregivers and us working with all of you to make them available to the whole network. So I think that that's something really important to look into and to discuss further. So thank you.
Let's go to Betsy and then Michael and Jeffrey. So Betsy, go ahead and jump in when you're ready.
Okay, thank you everyone, and hello everyone, and thank you so much for this, Sarah. It's really great. First of all, considering yesterday was Equal Pay Day for women, for white women, okay, so of the people that who are doing their caregiving, obviously not a lot of white women, but a lot of women, which brings me to concern about the term living wage, in that a living wage in California is much different than a living wage in a lot of other places. And this need is so tremendously great that what is the definition of a living wage? Is it 15 or is it more than that? Another question I have is, I was glad to see the evaluation part and all that, but then I wanted to see how you're going out when you say you want to expand this. Where are you going? Who are you going to? How are you? I get the whole program as an incentive package, hopefully, but are you going to, where are you going? How are we getting this?
Yeah.
How are we getting the huge numbers of people we need involved?
That is such, first of all, thank you, Betsy. It's great to see you, and such an important question. I'm going to answer that operational question that you just asked, and then I'm going to turn to Julia, because I really think if she's still on, it would be great to get her input on the concept of the living wage, because it is really critical. And I think it raises a great point about how we conceptualize that here in California. In terms of how, what I'm hearing you ask is how we're actually going to outreach and get the word out for this. You know, first we have to define the full denominator of workers that are eligible to get the stipends and the incentives, right? And then when we do, that's just half the challenge. The real issue will be how we make sure they know about it. So this is where we're working closely with DSS and DHCS and to use their channels of communication, because, for example, you know, CDA does not pay. We don't have a payment relationship with these workers. So we are not able to reach out to them, right? So we're going to use the network and connections through DHCS and through DSS. And I'll give one example of that. DSS licenses the home health aides. So they have a list of all of California's home health aides. The challenge is, we get into that gray area. Some of the home health aides don't provide training or don't provide services to Medi-Cal recipients. Some do. So we're trying to figure out how we can identify those that are in the Medi-Cal system. We can identify whether it has to be, if they have, you know, what the requirements will be there, and then utilize that list as a way to outreach to them. And whether it's through direct targeted mailing, outreach, you know, through public awareness campaigns, we're going to have to invest not only thought leadership, but also resources into getting the word out. Because if we're building all this and people don't come, it will not achieve our goals. So I appreciate that. And that's another area we're going to be really looking to stakeholders for input on. Susan, did you want to add anything to that in terms of the outreach issue?
Nope, you covered it very well.
Okay, thanks. And so I note that Julia was not able to stay on. So
Oh,
Betsy.
I'm here. I'm here.
Oh, you are. Okay,
Yeah, I'm
great.
here.
Awesome. Julia, did you want to provide some comments on the living wage?
Yeah, sure. It's a great question. You know, I did mention, I think, when we were covering the slides, that I think the lowest estimation of a minimum wage for California, for probably the part of California where the cost of living is lowest, is $18 an hour. And that's really low. I think a big issue for these workers is, I think, you know, we also mentioned that a high percentage, right, of the workers, are over half, are eligible and depend on public benefits. So there's a benefits cliff, right? What I've heard or learned from my conversations with United Domestic Workers and SEI 2015, who are the unions that represent the IHSS workers and a small number of nursing home workers, is that they estimate that a living wage would have to be at a minimum $24 to $26 to account for that benefits cliff, right? For the raise to mean something in California, and to account for the geographical differences, right? So that people who are living in the larger metropolitan areas also benefit from that. If you look at some of the other, like MIT has a wage calculator, and if you look at that for California, they say that the living wage for a family with, I think it's for a single provider with 2 children, is $40 an hour.
I'm sorry, what was that organization you just said?
It's the MIT.
Okay.
MIT, they have a living wage calculator.
Okay, thank
And
you.
I think it's just state specific, so it doesn't account for sort of differences within the state.
Yeah.
But it's even higher.
Fabulous. And then, so one last question, the slide production or slides that you just showed, we're gonna have access to those, yeah? Yes, okay.
Yes.
Thank you.
Thank you, Betsy. Michael, I know you had your hand up.
Yes, actually, good to see everybody. And Betsy, thanks for your question. It was one of the things I was thinking about. But in addition to that, I wonder, and this may come down the road with stakeholders, how we talk about this work, not only identifying who the folks are, but how this is explained to folks, the language that's used, to understand what a career pathway pipeline could look like for individuals. That'll be important as well, that folks know that wage is an issue, of course, but as you move through this pipeline, does that come across as, you know, these are promotional opportunities, if you will. I'm looking to do these steps before I go to a community college, or whatever those things are. I think it's important to consider in the process.
Thank you, Michael. That's a really important point of just how we actually explain what it is that we're trying to promote. And the word career ladder, career lattices can mean many different things to many different people. So we will have to think carefully about how to communicate it and how to ensure that people are taking advantage of the opportunities as they wish to do so. So thank you for that feedback.
Thank you. Let's go to Jeffrey.
Sure. Good morning, everyone. My question is related to kind of the intersection of disability and immigration status. So we've been working with DHCS on gearing up. Really exciting that Medi-Cal is going to be expanded to those ages 50 and up. And as part of that, we're learning that there's going to be a subset of that population that now will be eligible for IHSS. We haven't gotten a good kind of estimate or number on that. Somewhere, I think from the state LAO, I think we got like 2,500. We think that's an underestimation. So as we think about who is best positioned to take care of this newly eligible population, the first folks that come to mind are family caregivers who may be undocumented. So curious, if the department has good estimates on this expanded population, and then B, on the caretaker piece, as you're thinking through kind of the framework of these different categories of workers, particularly those in the gray market area. Just a recognition that many of them are undocumented immigrant women, and what resources are we providing? It may not be through IHSS, but what resources are we providing to for them to have access to some of these trainings, but also a living wage and contracts.
Really, really important points, Jeffrey. Thank you for that. Couldn't agree more. If before these people, if the family members are not in the IHSS system, but they are providing family caregiving, what can we do to support them in those roles, and what does that look like? That's certainly something that we're looking at too right now. And I appreciate your bringing up the question or the point about the expansion to undocumented individuals over the age of 50. It's really exciting. And I think, as you absolutely said, we have to think about what that means for service delivery and trying to estimate what impact it will have, and ensuring, again, cultural competency and language access. So that's something that is so critical in all of this, that, one of the potential partners in this, what's super exciting is that there's technologies that enable them to provide, develop trainings in up to, say, 15 languages. So that's something that we're really looking closely at. But I appreciate the comment and question about undocumented individuals. And I don't know if I don't have any specific numbers right now, but certainly we'll be working with DHCS to include that into our estimates. So
if I could, I'm sorry, Sarah, could I
go
add
ahead
to that a little bit? That I agree, that's an excellent question. And in the gray market context, there are some existing cooperatives that, if you're familiar with that structure, it allows membership in the cooperative. It's not technically employment. And so that is sort of regardless of immigration status. There is a cooperative in the LA area based out of the Filipino Worker Center called Courage LLC, and they are seeking to expand their network and to grow, both within Los Angeles and other areas within the state. And they are doing that in part with some funding through the Employment Training Panel, a special program, which the acronym is SEED, and I cannot remember what it stands for, but it's specifically for immigrant entrepreneurship. And there is I know one of the sort of the overlap between the gray market and potentially IHSS is that one of the questions that they are exploring in their effort to expand is whether in the counties where the agency model exists, and as far as I know, that's only 2 counties currently, but whether those public authorities could contract with a cooperative as the agency, thereby allowing undocumented family members to become IHSS providers. That's still very much in exploration, but it is something that people are thinking about.
Thank you, everybody. And I know we're running a little behind schedule, so I would encourage us to move on to the next agenda item. And of course, committee members, if you want to continue to engage on the workforce topic, you are welcome to use the chat feature to do so. And with that, I would like to welcome Connie Nakano. Or maybe it's Jillian that goes next.
Sorry, I'm here. Good morning, everyone. My name is Connie Nakano, and I'm the Communications Director for Department of Aging. So we'll be discussing a little bit about the Master Plan for Aging's outreach, including the Together We Engage campaign. We're excited to build upon current work that has already been done, and we recognize that there's much more to do to make sure the outreach is equitable and also reaching stakeholders and consumers that are representative of California's aging population. We are looking forward to working with our new communications firm, RSC, which will help develop and lead us through a strategic communication strategy. So I'd like to introduce Jillian Rice from RSC to give us a brief overview of what we'll be looking at over the next coming months. Jillian?
Hi, thank you, Connie. Good morning, everyone. Thanks for letting me join you today and take some time to talk about this. We're really excited to come on board and support the communications efforts. So I know we're a little behind, so I will quickly introduce RSC and myself and then talk a bit about our scope and kind of what you can expect to see. So for those of you who aren't familiar, we are a Sacramento-based full-service agency. We've been around for just over 60 years. We have in-house creative, media, digital. We do both public media, paid advertisements, as well as public relations for our clients. We primarily work on social impact marketing. So mostly we do behavior change, public awareness campaigns, rather than, promoting sales for private companies. So we have a lot of government foundational clients, recently supporting a lot of the COVID efforts out of the governor's office, CalFresh, First Fives, things like that. So a bit about me, as Connie said, my name is Jillian. My pronouns are she and her. I'm an account supervisor and I'll be the main lead for our team that's working on supporting the MPA communications. A bit about my background, for the last decade, I've worked in communications related to public policy. Most of that's been in the healthcare space, in public, private, nonprofit. So I have a bit of a taste, all around carrying policy ideas from development to implementation, and a lot of work in the outreach space related to healthcare programs. So worked with a lot of diverse communities around different health topics, oral health, behavioral health, culturally competent care, working on access and quality issues, health disparities, and delivery system integration projects. So a lot of familiar acronyms, a few familiar faces on this call. So again, excited to dive into this. So as you're all pretty aware, there's a lot of moving pieces in the master plan. So when we're looking at our communications consulting and what our project deliverables and scope are, I just want to kind of give a framework. We just had our kickoff a week ago, so barely diving into the work, and we will be supporting this through at least the end of the year. Our major task is really helping with the MPA brand communications. So working on a communications plan, auditing kind of the existing materials, the existing communications channels, and really working on how we can improve messaging and tell that story better. We will also be engaging in media relations work throughout the state, as well as some partnership outreach related to some of the goals and events that CDA has planned throughout the end of the year as well. So in our communications plan, as I mentioned, our goal really is to increase the awareness and participation in the master plan. So, telling the story of the MPA in a more human and accessible way, which is always a key thing, I think, for healthcare initiatives. Telling why this is important for all Californians, not just older adults. And then when we look at when we're gathering input, who are we gathering it from? How are we gathering it? Making sure we can make any improvements there. Some of the different target audience buckets we're looking at are the public, stakeholders, philanthropy, and the legislature. So a lot of audiences to work with. I think one of the main things that I'd love to hear from this group is just, an invitation for your feedback. Some of the things that we're already looking for in terms of reaching underserved and diverse communities. I noticed that there has not been a lot of different languages that communications have gone out in. There's multiple websites. The collateral has been very kind of stakeholder focused rather than public focused. And so those are things that we're already kind of looking at. Who is at the table? Who needs to be at the table that's missing? Are we leveraging the communications channels that we already have access to? And are we simple enough in our messaging, for it to be digestible? So again, those are a few things we're starting to work at, a broad picture of our project and task to date. But would love to hear from you guys if you have input on how we can improve these areas, you know, challenges or successes to date to build upon, would welcome that feedback as well.
We've got a couple of hands raised, and I'm wondering if we can go into gallery mode, Nancy. Let's see, here we go. We've got Donna and then Michael. Go ahead, Donna.
Okay. Hi, so one of the questions was, what else could we add? And I don't know if this is something we can do, but it would be nice to have a database of where presentations are or where we've done things about the master plan on aging, so that maybe if somebody is talking about it, like whenever I talk on things, other people could just join, because there would be a link if it's a public forum, because many times I'm doing things and it is a public forum and anyone could join, but it's not directly with CDA.
Mm-hmm. Great, thank you. Michael?
Hi, Julian. You may already have this baked into your process, but based on work that ARP has been doing with Donna and with 211 on a Latino caregiver program, one of the things that we found that's really important is which words do or do not translate, and how you talk about the whole range of what the MPA covers, and that level of sensitivity when it comes to messaging for what may be meaningful or not to certain populations.
Mm-hmm. Definitely.
Thank you, Michael. Anybody else? And I just want to highlight, Jillian, that there's some requests for contact information in the chat if you're willing to share with committee members.
Definitely.
Great. Not seeing any additional hands. So we will move on to, I believe our next segment is public comment. Thank you so much, Jillian and Connie, for that great presentation. Wonderful. Thank you. So just a reminder for those who are joining us today, public comment, if you are using your computer, you can use the raise hand icon on your Zoom toolbar, and that'll put you into the queue for a verbal comment. Those joining us by phone only, you can press *9 and that will add you to the queue. I'm seeing a couple of hands up. Manchi, I apologize if I'm mispronouncing. Manchi, your line is open. Okay, we'll swing back around and maybe that hand was up on accident. And I'm not seeing any additional questions or comments. So maybe what I can do is turn it back to Susan and sort of put Susan on the spot to either close out or to direct us to have a little bit more time with the committee.
You got it. Thank you, Maria. And thank you all for your, to our presenters. Thank you. Those were two great overviews. And to the committee members, thank you for your, well, actually 3 great overviews. We had 3 presentations. So thanks to all of our presenters and to your thoughtful questions. I'm glad that we have a few extra minutes before we wrap up here. There are a couple of things that I wanted to circle back around on at the close of the meeting. So the first is in the master plan for aging org chart, so to speak, we have the impact committee that Kevin Prindeville serves on, and Kevin's with us today. So impact is the group that has been charged with, you know, sort of monitoring and oversight and stewarding the master plan for aging. And we have made a commitment to the impact committee that we will bring, we will summarize each of our meetings for the impact committee so they know what was talked about and what's important to carry forward. So we've taken notes today, but I wanted to hear from you if there's anything that any of you on this advisory committee would like to share with the impact committee at their next meeting that you think is important to carry forward to that group. Of course, Kevin is here, so he's listening as well. And but if there are any thoughts for the impact committee that you'd like us to convey, we're trying. It was a little bit of a cart before the horse, but now we're syncing up where these meetings will feed into the next impact committee, so we're not in arrears any longer. Any thoughts from the group? And you can follow up after the meeting with me as well, or with Kevin as your liaison to that group. Not seeing any hands raised. Okay. And then I did want to just go back to what I shared about nursing home issues. I'm going to put in the chat. I hope many of you are familiar with what was released by the White House in February. And I'm going to share with you the full list of recommendations that came out. And I wanted to call your attention. You know, I often do a word search for equity on documents to see, and I was thrilled when I did the Control F on this document and saw that equity was mentioned 16 times. And then I realized 15 of the times it was equity partners for nursing home purchases. And the word equity, as we use the word equity, was only mentioned in the final bullet in this document. And if you take a look, it says equity lens. So in the staging of things with the May revise and the nursing home rate reform efforts taking place before the end of June in California, I want to underscore how important the voice of this committee is in whether you use your voices individually through your organizations or collectively. If it were as simple as some principles and values of this advisory committee that you wanted to share and be on record, if you would consider that in between, you know, by the time this group meets again in June, the budget will be final or close to final, and the legislative session will be wrapping up. So if that's something that this group wanted to pursue independently and put together some thoughts, a simple letter and comments, building off of that final bullet in the White House press, you know, I'll pull it up, and at the very, very end, it says, integrate pandemic lessons into nursing home requirements, and it says using an equity lens. So knowing the demographic profile of who is on Medi-Cal in our state and who is living in California's nursing homes, we would really welcome your input on that topic. And then from the CDA perspective, we'd love to hear now, put you on the spot or in between meetings, what topics are of greatest interest to this group for your next meeting. One suggestion, and it relates a bit to this, to nursing home reform, but CDA now has now established the Office of the Patient Representative, and Susan Rodriguez is leading that effort and building a team around her. This office is focused on individuals in nursing homes who do not have family, who are not represented. And this is well beyond the role of the state long-term care ombudsman, but we increasingly are seeing nursing home residents in our state who are unrepresented. This ties to the a little bit of what Catherine mentioned in the elder and disability justice space, and it's a topic that's being discussed at the Elder and Disability Justice Coordinating Council as we build out that landscape across the state for APS, long-term care ombudsman, legal services, surrogate decision-making, and a host of issues around advanced directives, placement issues, transfer, discharge, So that might be a topic this group might want to hear from in the future, the new Office of the Patient Representative. And now I'll stop talking and would love to hear any thoughts from all of you. Amanda has her hand raised.
Hi, I just wanted to, building on that, thank the folks on this committee who volunteered to join the Elder and Disability Justice Coordinating Council's Equity Framework Work Group. And I also wanted to let you know that there is a separate work group for that council that is focused on building out that landscape of what is the Equity and Disability Justice Network in California and identifying those gaps. So if anyone here is interested to do some of that work with the council members, please go ahead and send me an email. I'm sure they'd be happy to have additional folks on board. Thank you.
Great. And Susan, I'm wondering, before we log off, it does look like we have one audience member who has their hand raised. And I know we were ahead of schedule, so maybe we can swing back around to that if you're open to it.
Absolutely.
Great. Cindy, we've opened your line.
Hi, thank you so much. Thanks for everything. Really good stuff. I just want to know, and you may have said this and I had to walk away for a few minutes, and I want to know if there is a phone list or a contact list for the people we should get in touch with if we want to get involved in a subcommittee. Just curious, I'm unclear about that. And I've been unclear about it, and I want to make sure that we all know who to reach out to.
Great question, Cindy. I think the best route would be, I'm assuming you're talking about work groups writ large and not just focused on this one, would be to use the Engage inbox, and we will get right back to you. And that way you can open a dialogue with somebody to meet your needs and match with your interests.
Okay, thank you.
Mm-hmm. Vince and Bernice have questions or comments.
Hi, this is Vince Christoph. I'm a member of the Equity and Aging Committee. When we talk about the nursing home, I have been the caretaker for my parents who have been in nursing home, and my understanding is there's a number of things such as financial abuse they're supposed to support. So I've been in a situation where they have reported several times, but then nobody ever follows up. And so is the committee that was just mentioned, is that something where you could go and follow up and find out more about this kind of thing? I don't want to go into, I could go into the whole thing that we have. I've also, as I tried to pursue this, I've been told things like, well, you just have to understand your parents, or they'll make any money for anyone to care. But repeated calling and reporting and contacting adult protection services and the ombudsman in 3 counties, I've never been able to really get anywhere. So I'm just wondering, where do we go for that?
Vince, that's you broke up a little bit there, but I would invite you to I'll put my email in the chat. If it's more of a individual nature, I'm happy to help you troubleshoot for your own family. And then for the public and anyone listening, please use the Engage inbox, and we will promptly follow up with any questions or direct you to the right person for an answer. But I will share also my email right now.
Bernice, I think you were next.
Yeah, thank you. Susan, and you asking kind of what other topics, right, should come to this committee. I think we've talked about it before. It's our health workforce, right? It's in such critical condition that I have to uplift it in this space as well. And in particular, the language part of it, right? As we continue to, extend coverage, right? We got to ensure access is actually real. and that folks can access doctors that speak their language, a caregiver that speaks their language. And so we often struggle. I work for a community clinic system here in the state of California. And so we often struggle, and even on our PACE line of business, for just that pipeline. We're in such critical condition is what I'm starting to say. And so I just, however we can uplift that, any data that can be shared, the equity lens over that $1.7 billion proposal from the governor on the health workforce, which is historic, right? But then you start looking at, how many of these dollars are going to go towards, Latino, Spanish speaking initiatives. And I uplift Latinos because this is California, right? And a lot of the folks that are going to be eligible for these programs and coverage expansions, et cetera, speak Spanish. And so just want to uplift it. I'm not sure if it's an opportunity for data, the topic here in the space, using us to advocate and, really push the governor's office, work with our elected officials, whatever it may be, right, to really elevate that. So just want to uplift that in this space.
Thank you, Bernice. I hear you. And that's a great example too of something that I will convey to the Impact Committee and of course to our colleagues in the Health and Human Services Agency and the Governor's Office. And you raise a really good point in the slides that were shown with, over $900 million. The money's moving very fast because of the constraints put on us by the federal government. But if we can collect some basic data at the front end, we will not be able to go back in a few years and look back. It won't exist. So I hear that. And it's also something in the $1.7 billion that was proposed in the January budget. We can be a little bit more thoughtful because those are state dollars. So please keep communicating that, but I also will convey it for you.
Thank you, Susan.
All right, Maria, I'm not seeing any other hands raised or any chat or Q&A at this point.
I think we're on track to end a little early.
Great. Well, thanks everybody for your participation today, for your contributions and participation. I'm looking, I think every member asked a question or made a comment, and I love seeing that. We look forward to being back together again in a quarter, but that will not be the next time that we see all of you. We hope we see you for our Wednesday webinars. And I know many of you cross over to other stakeholder groups. And anytime you have a thought, question, or comment, just send it our way in between meetings so that we can build the best agenda next time for this group too. So thank you. And Jax, thank you so much for sharing. I had neglected to share the CDPH announcement. I'm really glad that Jax put that in the chat because that is time sensitive. So thank you all and have a great rest of your day.